Hello, I'm Dr. Gay Carlson, President of the American Academy of Child and Adolescent Psychiatry, with I think it's number 36 of my Screenside chats for our AACAP members. My goal with the chats has been to share timely clinical practice and other important information from experts on key topics during the COVID-19 pandemic. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I've wanted the topics to be informative, relevant, and interesting. I'd like to wrap up the discussion of why and how irritability and outbursts became an object of study in child and adolescent psychiatry. If you look at the graph of published studies on PubMed about irritability in children, you see a graph which gradually starts to take off in the mid-1980s, when the bipolar controversy in children kind of started to take off too. But it really started to take off after Y2K, after the year 2000, which is when the NIMH convened a roundtable where those of us interested in child and adolescent bipolar disorder wrestled with some of the questions that I'll be asking shortly. The person who has most tried to produce a body of research to answer the chronic irritability or early onset bipolar question is Dr. Liebenloft. Dr. Liebenloft is a psychiatrist, a senior investigator at NIMH's Intramural research program, and has been the brains behind formulating the approach of comparing classic episodic manic depression with severe chronic irritability, which became severe mood dysregulation, which became disruptive mood dysregulation disorder. Her data has concluded that the two entities are different. And since 2013, her work is focused on understanding the mechanisms mediating irritability with the ultimate goal of guiding novel interventions. Dr. Liebenluft is a member of the National Academy of Medicine, one of the highest honors that a scientist can be given, and supersedes any of the other credentials I might have been tempted to list and go on and on about. She's also written over 300 papers. On a personal note, besides all the praise you can heap on her for her innovative work, Dr. Liebenloft is one of the most sensible, generous, and undefensive people I have found in our field. She's actually coming to us now from Martha's Vineyard. This is not a set that she's got behind her for Zoom. This is where she really is, because she's on vacation after having worked really hard getting her lab reaccredited or reapproved or whatever. And she was nice enough to do the Screenside chats with us. And I wanted her to be my last interview for Screenside chats because it completes a circle that began over 20 years ago for her and over 40 years ago for me. So, Dr. Liebenloft, you know the expression that goes, people who don't know history are doomed to repeat it? For the younger people in the audience, can you harken back to the golden days of yesteryear when the question really was, how early can bipolar disorder be diagnosed? And I mean mania. I don't mean NOS or high risk. I mean somebody that's, to use Kay Jamison's term, stark raving mad manic. How early do you think that can be diagnosed?
Well, thanks. First, I want to say, Gay, how happy I am to be here. And in terms of your seeing me as generous and non-defensive, I just want to say that I see you very much the same way. Throughout all of the kinds of ups and downs and ins and outs of this issue and how it's played out, you've always been phenomenally supportive and generous and basically just wanting to get to a place where the data drove practice and how we conceptualize things. So I just want to say how much respect and affection I have for you and your part in all of this and in child psychiatry. And also to say that this issue about irritability is something, as you said, that you've been working on for a very, very long time. Certainly, and your work preceded mine and informed it. And for that, I'm very grateful, as well as for your friendship. The bipolar disorder debate, if you will, as folks know, bipolar disorder, really since the time of the ancient Greeks, has been defined as an episodic illness. an illness where people have episodes of mania and episodes of depression. And what defines an episode is a distinct period of time where the person's different from the way they usually are. They're different, when they're manic, their mood is different. It's euphoric or irritable, as the classic definition. And at the same time that they have a change in mood, they have a change in other symptoms. Their speech is more rapid, they're sleeping, they need less sleep, they're more active. And similarly, for depression. What happened, when would you say, Gay, like the late 1990s, early 00s, is that a number of folks in child psychiatry became proponents of the idea that bipolar disorder, while it presents episodically in adults, presents differently in children. And that instead of presenting with these episodes, what happens in children is that there's chronic severe irritability. So no episodes and not much euphoria, but a lot of just chronic severe irritability. And then, of course, symptoms of ADHD. I mean, that in many ways, the increased activity, decreased need for sleep, talking rapidly, taking risks, those symptoms that could be seen to overlap between mania and ADHD also played a role. And what happened at that time was that the numbers of children receiving the diagnosis of bipolar disorder skyrocketed. And actually, it was a situation that made it to the news. It was in newspapers and magazines, and that really was changing practice. And so we and others did work in this regard also. I mean, Gay, the folks at Pittsburgh, and other groups also got involved in the question of, okay, can we bring data to bear here? And to cut to the chase, in some ways, the most powerful way to conceptualize the question was, what happens to these children as they grow up? If chronic severe irritability is a pediatric presentation of bipolar disorder, and if we're going to accept for adults the definition of bipolar disorder that's been around for such a long time, then you would expect that these children, as they got older, would develop manic episodes. They would begin to show the adult phenotype. So we and others did a number of studies. Actually, given the long-term longitudinal data that were needed to address this question, it was often post hoc analyses of existing epidemiologic data sets. And using those, we and others found that children with chronic severe irritability were not at increased risk to develop the adult phenotype of bipolar disorder as they got older. Instead, they were at somewhat increased risk, significantly, not huge, but somewhat increased risk to develop anxiety disorders, depression, suicidality, and to have decreased educational and income attainment as they got older. So that all showed that irritability, which, as this audience knows, is very common as a presenting complaint for children, that irritability is important and that it does confer long-term risk in the future, not all, in addition to impairment in the here and now, but that it's not strongly associated ultimately with bipolar disorder. The other point to note is that family histories do not support the idea that bipolar disorder and irritability are tied up together. Children, the offspring of adults with bipolar disorder, do develop irritability, but not at any higher rate than they develop unipolar depression or any one of a number of other, or bipolar disorder itself, or any one of a number of other illnesses. Whereas there are data that chronic severe irritability is genetically associated with risk for anxiety and depression. So that longitudinal association we see amongst anxiety, depression, and irritability is also reflected in genetic studies. So I would say those are those are the data that basically led us and others to come to the conclusion that chronic severe irritability in children is not a pediatric phenotype of bipolar disorder.
You know, one of the things that when I got into this business, it was mostly to distinguish, and it was in adolescence, it was to distinguish mania, bipolar disorder from schizophrenia. The zeitgeist when I was I was coming up, right, was that if you were crazy as a teenager, you had to have schizophrenia, and it turned out that it was almost equally, if not more likely, that you had mania or possibly a psychotic depression. So, you know, that the schizophrenia part brings me to Judy Rappaport, who, as you know, was at an IMH for many years. And
we collaborated on this.
And you collaborate, right. Anyway, she took years and years and years to come up with really adult schizophrenia that started in children. No exceptions that you know, if you're a little bit flaky or you're weird or there's a number of things that kids have that make them look like maybe they might be at risk for schizophrenia, but she really wanted them to have schizophrenia. And it took her years to find a decent size sample because it occurs, but it doesn't occur very often. And there's a whole bunch of other things, other conditions that kind of touch on it, resemble it, but she sort of put them in a different bin. Would you say, can I get you to commit publicly to that for manic depressive illness, it might be the same sort of thing. You can find classic or early onset manic depressive illness in children under the age of 12, but you don't find it very often. What you find is these possible lookalikes, the ones that you say, well, it could be, you know, it might be. And so that in some respects, that's the kind of thing that we're talking about. And I make a big deal out of the mania piece, the bipolar 1 piece, because I do think that when you start getting into the broader spectrum things, you're in a different place. I started out wanting to know, and I'm good friends with Kay Jamison, so I've used her for this for years. Can you look like Kay Jamison under the age of 12? If you look at Kay under the age of 12, she clearly was an intense and moody person, but she did not have what she got when she was 17. And so I guess my thinking is we can say yes, or can you say, I mean, that's what I say. Yes, you can have card-carrying manic depressive illness under the age of 12, but you don't find it very often. You find risk factors, you find depression, you find things that you're not sure about, but you don't find many Kay Jamisons under the age of 12.
I totally agree with that. First of all, I want to say that Judy Rappaport's work with schizophrenia was an inspiration to us in undertaking the work that we did. And in some ways, you know, in terms of defining a phenotype and then testing it in different ways, we were inspired by her work. I completely agree that one can find children under the age of 10 who have classic presentations of bipolar disorder and, you know, clearly appear to who have clear episodes of mania. As you say, that's really the kind of rare part of it, right? Because the depression part of it is more common. And so I totally agree with that. But that it's not common. So you can see classic bipolar disorder. It's under the age of 10. It's not common, but you can see it. And also that there are these other phenotypes that confer risk. And in fact, the Pittsburgh group has their risk calculator where they look at a number of different variables to try to establish the risk. But like Kay, so you wouldn't diagnose her with that presentation. You wouldn't diagnose that presentation as bipolar disorder. But, the fact that she later went on to develop it is, consistent. But there will also be children who look like what Kay looked like who won't develop bipolar disorder. And of course, the tricky part is knowing who's who.
Mm-hmm. Right.
But absolutely, bipolar disorder does present before the age of 10, classic bipolar disorder.
So the other argument was and is that that what children are showing isn't classic manic depression, but more and this was Barbara Geller's, I think, point, was that 20% of adults with bipolar disorder present with the chronic rapid cycling mixed episode. They're really complicated and mood dysregulated people. They are not your classic manic depressive episodes of mania, depression, euthymia people. They're sort of chronically unstable and dysphoric and so forth. And I have no doubts that that's true. I remember when I was working on Fred Goodwin's ward, we had a number of those. So the argument is that the kids become that, not that they become more classic manic depressive illness. What are your thoughts about that?
Yeah, so that's interesting because actually, like you, I studied adults with rapid cycling bipolar disorder at the NIMH. The issue about some of it becomes how short can an episode be and still be an episode? Can, something that's measured within hours still be an episode? And of course, that becomes problematic because how can you measure changes in need for sleep in the course of a couple of hours? And where does a temper outburst end and an episode begin? So with the adults with rapid cycling bipolar that we studied, the cycles weren't measured in hours. They were still measured in days. It may have been 2 days, but it wasn't 4 hours, and I think that's where things become very tricky. And
let me, Lynn, because you're making an important point, but there's one other point that needs to be made. Mm-hmm. And that is they're having their mood lability within an episode. So they haven't been like that since the age of 2. They develop that. And within the episode, they have rapid cycling. And maybe for 2 hours, they are silly. And then another 2 hours later, they are depressed. But that's not the episode. The episode is the big thing within which those ups and downs
and
are
then
occurring.
The question is also how big a big thing can it be? So, for example, if you have a child who's 12 years old and you say that child has had a 9-year episode within which they have had, ultradian, ultra rapid cycles, that's what you end up with. And if you look at, the data, like, for example, of the risperidone, Depakote, right, study, lithium study, those children had episodes that were 9 years long, during which they had frequently been treated with stimulants. And it's a little bit hard to map that onto an episodic illness. It becomes quite challenging.
Yeah. So what happens, I think, and hope like lightning bolts don't take me out when I make the sentence, but I think one of the things that happened with this is we ended up being, we started out using systematic, structured interviews so that we wouldn't end up having arguments about what it was we were talking about. You call it schizophrenia, I call it mania, somebody calls it anxiety, depending on our religion, that's how that was what the interviews, structured interviews were supposed to stop. But I'm afraid what happened was that when people read the questions, and if people don't know what the template looks like, and you're sending out your research assistants and your graduate students and all the people that did the work, and you send them out and they ask the question and the person says yes, or they don't know what you're talking about, and you finally say, oh Christ, I'm just going to put down yes and get on with this. You end up with people who meet the criteria, but they don't have the disorder. At least that's my opinion on the subject. And so to me, that's, I think, one of the things that happened, that we had a bunch of people who you could tick off all the boxes. And my God, you said, geez, look at this. They tick off all the boxes. They must have the condition. And so we had the tail wagging the dog. And I think we still have the tail sometimes wagging the dog. But I think that's how we got into it. Nobody got into it because they wanted to sell drugs. Nobody got into it because, they had some message from God about this. They got into this because they were trying to follow the rules and do what they were supposed to do. But and Ken Kendler writes nicely about this, they ended up ticking the boxes, but they didn't have at least what you and I, who took care of a lot of adults with this condition, recognized as what the adults had.
Well, and I think the other point to raise here is about external validity. So you can do the cross-sectional phenotyping. And I think what you're saying is that there's a difference between, which I agree with, there's a difference between ticking boxes and thoughtful phenotyping. And I think also the training and experience, but the training, I mean, there's many ways to do a case ads, some of which are more highly clinically sophisticated than others, right? But in any case, there's only so far you can get with the cross-sectional kind of phenotyping, and that's where the longitudinal data and the genetic data, I wouldn't have standing alone, the genetic epidemiology I was talking about, but that bolsters it. I think the most important data are the longitudinal data, but, by the other external validators that you had. For example, another thing would be treatment response. So that's another issue of getting, there's only so far you can get. Well, let me make it a more positive statement. And here, this is very much what Ken Kendler talks about all of the time. You need external validators, and it was the external validators which were so important, I think, for the field to accumulate in order to address the question, test the question of whether or not these children have bipolar disorder.
So we go from ultradian cycles to outbursts, which, as you know, has been, I guess, what we ended up focusing on with my AACAP presidential initiative, because they were I think, the core of the problem that people were so earnestly trying to define, because they are so crippling to the kids and families that have them. And so
exactly, and I'm sorry to interrupt you, but a really important point is how what people were basically trying to do is understand these severely impaired children, understand what they had and what to do about it. Exactly. Go on. I'm sorry.
Yeah. Well, no. So that's because I wanted to slide us just briefly into the outbursts business, because for me that was what I wanted to focus on, and I guess I've always had an interest in communication and communication disorders. So I want to be able to be kind of precise about it. And rather than calling something irritability, which it is, I mean, obviously if you get really mad really fast, you're irritable. But I wanted to be able to delineate the what you did part of it as what we're trying to focus on. And if we could give that a name, and if we could not isolate it, but if we could try to understand how ubiquitous it was or how transdiagnostic it was, maybe we could come up with a way of being able to label it without a diagnosis, because I think the thing about a diagnosis is to make it a diagnosis, you've got to have a lot of other things to go with it. So if I have a headache, I have a headache. But before you say I have a brain tumor or I have cluster headaches or whatever it is, it's got to have other stuff. All I wanted to do is say, let's look at the outburst before we worry about the other stuff. And I hope that we will be able to come up with a way to be able to define and isolate them, and then be able to see whether, if you tack them onto ADHD or anxiety or manic depression or a schizophrenia or borderline or anything else, whether that matters, whether the outbursts are like the fever or whether there's something unique about it, that they're different when you have an anxiety meltdown versus an autism meltdown. We're not there, but that was, I guess, the hope that I had with it.
Well, and I agree with you. And I think there's a tremendous amount of work to be done in terms of the nosology of outbursts and the nosology of irritability. And, talking about DMDD, I mean, I say, on a good day, I'm about 65% pro. I think there's a lot of pluses and minuses to it. I think there's a lot of work, first of all, and there is work going on in this regard now, trying to obtain or learn about developmentally sensitive, normative definitions, if you will, of irritability. Getting more epidemiology on exactly how does this present at different developmental stages. And one thing that there's been very, very little research on is also how culture impacts on that. I mean, there are reasons to believe that different cultures would view irritability in youth different ways, and normative parenting in those cultures. So, but we don't even know in a developmentally sensitive way how the spectrum plays out, what we should consider impairing and not, what predicts risk for, future difficulties. There's a lot that needs to be done, just learning the basics.
Well, I'm tempted to ask you my last question, even though our time is just about up. And that is there anything that you would have done differently? Rewind back to Y2K. Is there anything you would have done differently if you had it to do it over again? Or has this map gone the way you wanted it to go?
That's a really hard question, because there's always things you look back on that you could have done better. And certainly
better, different. Different.
Well, I mean, I think the whole DMDD thing was a particularly difficult kind of decision. I think that's the biggest, most difficult one. Now, since then, of course, I've been really focused on brain mechanisms of frustration. And, that's really tough. The brain behavior associations or predictions, the entire field, and not just child psychiatry, but psychiatry and mental psychology, we're all really struggling with that. So I look back on that. I'm really, really pleased that Melissa Brotman in our group is focusing on therapeutics. We've done, obviously, we did a trial of stimulants and SRIs, which showed some degree of help for it, but I think we need incredibly much more treatment research. I'm glad that Melissa's doing that from the psychotherapeutic perspective. Other groups, the more we do of that, the better. So, there's always things one could do different and better. But
in general, this has gone pretty well as far as you're concerned.
Well, what do you think?
I think it has. I think you're to be congratulated, and I hope you knocked it out of the park with your review over the past.
Yes, well, I'm pleased, but thank you for your kind words, and really thank you for your support over the years. You really played a very, very central role when we were getting started, and throughout, but in particular when we were getting started. I remember, I don't know if you remember this, we shared a banana at and had the first time we met and had a really important conversation. And you, as a leader in the field then as now, just really was so supportive, and it made a huge difference. So to the extent you're congratulating me, I stand on the shoulders of giants such as you.
Between the two of us, we make a normal person.
And the two of us, we make a normal person, exactly.
Okay. Thank you so much, Ellen.
Thank you, Gay. It's really been a pleasure. And congratulations on your presidency.
Oh, thank you very much. And thank you to our audience who have borne with us over the last couple of years with COVID and the Screenside chats. I have really enjoyed doing this. Thank you.
Bye.
Thank you all very much for tuning in. This is Gay Carlson for AACAP's Screenside Chats.
Provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.